Morning again, or is it still not afternoon? So I'll be giving the first talk, which Dr. Sheetal had to give, but she had to run for a free paper presentation. So the talk is when to smile and when not to. And we have been doing smile for the past 10 years. Like Dr. Kumar said that we do surface ablation, but I've hardly done surface ablation. Mainly we do smiles. So we look at specific indications for smile, when to smile, when not to smile, and what are the advantages. So some of the specific indications are patients who want to play contact sports including boxing, wrestling, karate, football. All these are sports where if you have a flap in the eye, it is prone for flap dislocation. So either you select surface ablation or smile. We prefer smile because the visual recovery is faster and patient satisfaction is better. There's an 80% less side cut than a LASIK flap. So you can just do a 2 millimeter incision which is covered by the upper lid, and so the corneal surface is intact, and it's very good for people who want to do contact sports. So and of course you don't have any flap complications like microstriae, flap dislocations, or epithelial ingrowth. You also have patients with pre-existing dryness, especially contact lens wearers. Most of the myopes are contact lens wearers, and they come with some amount of pre-existing dryness. Also, many of these young patients are IT professionals who are looking at the screen for more than 6 hours a day, and this excessive screen time also gives rise to some amount of dryness. You can also have perimenopausal women due to hormonal changes who have dry eye. And we all know that with LASIK, we increase the amount of dry eye. There are several studies comparing LASIK and smile which have shown that the corneal nerve regeneration is much better with smile. And this is from one of the studies by Professor Shimizu in Japan, where he showed that the 1 month post-op recovery and nerve regeneration is much better in smile than with LASIK. This is because there is less transaction of the upper corneal nerves. So you know that the corneal nerves enter somewhere at around 120 microns into the cornea. So especially if you have a deeper smile cap at 140 microns or 150 microns, then the incidence of dry eye is less. We did a study, and it's published also, comparing 160 micron cap to 100 micron cap, and we found that especially in the first 3 months, the dry eye was less with the 160 micron cap. I think Narayan Netralaya also has done a similar study where they found that thicker caps, again you have less dry eye. So that's, but with LASIK, of course, you transect the nerves, and then you have slower recovery of the dryness. Then the third indication is high myopia, more than 6 diopters, because here the corneal biomechanics are much better with smile, because when you cut a flap, then the flap does not contribute to the biomechanical stability of the cornea, unlike smile. And so the biomechanics is not only about ectasia, it also is about long-term stability of the refraction. And if you have weaker corneal biomechanics, then you can have changes in the refraction. A 10-year study by Walter Secondo and group found that in high myopia, again, the smile was very stable, and the regression was only about minus 0.35 diopters in 10 years. So it shows very effective and stable procedure. And right now, smile is approved for up to 12 diopters of spherical equivalent commercially, and up to 10 diopters of myopia. If you look at the zone of flattening, we also did a study where we found that the zone of flattening, so what is attempted versus achieved flattening by doing differential maps, pre and post-op keratometric differential maps, tangential maps, we found that the zone of flattening on an average with LASIK was about 69%, whereas with SMILE it was about 80%. So you get effectively larger optical zones with SMILE, and this helps in better night vision. And also many of these myopes have large pupils, and so when you have a large pupil and you have a small optical zone, then there's a higher incidence of spherical aberration. This was a study done by Ektet Chansui from Thailand, and he found that if you look at the induced aberration, the red is optimized LASIK and the blue is SMILE. With SMILE, the amount of induced spherical aberration is much lower than optimized LASIK, especially so with increasing refractive errors. So here this is about 10 diopters. So you can see that starting from 1 diopter to 10 diopters. And with SMILE, with LASIK, the spherical aberration increases. So again, night vision, night myopia is more common with LASIK and large pupils. Why does this happen? This is because excimer-based procedures have loss of energy in the periphery, what is called as the cosine effect or the summer-winter effect. There is fluence projection losses in the periphery, because in the center the beam is round, but as it goes to the periphery it becomes elliptical. There's a lot of energy loss, and so the ablation is not adequate. So you don't get a aspheric cornea. That's why in wavefront optimized they give extra spots in the periphery to compensate for this. But whereas with SMILE you have, so this is the induced aberration and the abnormal corneal shape. Whereas with SMILE you have a clean excision of the tissue, there is no loss of energy in the periphery, and the natural aspheric corneal shape is preserved. Of course, SMILE has its limitations. So what are the limitations? There is no automated cyclotorsion compensation, and because of this, treating high cylinders you can have some amount of residual astigmatism, so you always have to mark. Again, large angle kappa, you cannot compensate for this, but usually the patient is fixating on the visual axis. Dr. Pooja, I have my talk also, followed by this. So hyperopic correction right now is not present, and mixed astigmatism cannot be treated. Wavefront and topography based procedures are not available. Enhancement can be done either by LASIK or PRK. SMILE on SMILE is not commercially available. But we did a study and published this in JRS, results of intraoperative manual cyclotorsion compensation for astigmatism, and found that results are very good if you do that. And we also described the way to compensate. So you mark the 0 180 degree axis, and then you can, after suction, you can rotate the cone and align the reference axis. So then you don't have, then the correction of astigmatism is better. The Visimax 800 has pattern rotation, and it will shortly be automated. So this takes care of this. And centration guide is very important, especially for large angle kappa. Here is eye with a large angle kappa, and you can see that there's a difference between the line of sight and the pupil center. This is on the Visimax 500. The patient usually fixates along the visual axis, so there's not a problem. With the 800, you have a assistance of the central line, where you can actually identify the visual axis and then center on the visual axis. So then you get a very good centration. This is a case of a large angle kappa, almost 600 microns. You can see the difference there between the pupillary axis and the visual axis, and it was treated on the visual axis. And you can see this is the post-op topography, and the patient had 6/5 vision uncorrected 2 weeks after the procedure. For mixed astigmatism, right now there's no commercial software, but we have an open software, so we treated mixed astigmatism also, and then this was like plus 3.3 with minus 4.15, and this was the surgical video. You use a hyperopic license, you use a medium cone, and then you can treat this. You look at the pattern, so you can see that it's very different from your usual SMILE pattern, and Okay, this is how you treat mixed astigmatism. We have treated about 13 eyes and then we'll shortly be publishing the results. That's the cap cut. But let me go on to the topography. You can see that this is the topography, this is the pre-op and the post-op, and the difference map. In the difference map, you can see the nice correction of the astigmatism. Hyperopia is just now getting CE approved, and we were part of the global trials for hyperopia, and I'll show you one of the examples. This was 21-year-old female, 5.5 diopters of sphere, and post-op you can see the correction. It was plano with 0.25 cylinder, uncorrected vision of 6.6. This is the difference map, and you can see the nice steepening here. This is pre-op and post-op, nice steepening of the central cornea. So one day most refractive surgeries will be SMILE, and there will be very less contraindications for SMILE. Thank you very much for your attention.